So, this discussion will be about cardiovascular problems or dysfunctions in the pediatric population. Most of this is going to be new information for you because we're going to focus on especially congenital defects that result in cardiovascular disorders in the population. So there are some signs of cardiac problems that oftentimes are a little more vague. Sometimes it can be very notable, like cyanosis, especially with feedings or any kind of activity. But some of it can be a little more subtle, like just failure to thrive, poor weight gain. That can be a sign of a cardiac disorder because they are using so much energy and so many calories just for basic functions like feedings, crying, things that increase their cardiac output, that they are not able to gain weight from what they're eating, even if they're eating totally fine. So we talked about way back in newborn, if you go back, how if they don't come up to their birth weight within 2 weeks, or if they lose too much weight, then they'll start looking at potentially other problems. This could be one of those potential other problems they may look at, especially if there are other symptoms associated with it, because that could mean if they have a significant enough cardiac problem to affect their cardiac output or make it harder to meet their cardiac output, they're burning so many calories they're not able to gain weight. So some of the other things, you can have vital sign changes such as your increased heart rate, your increased respiratory rate. Usually blood pressure is not affected. Again, we're not usually worried about blood pressures in under 3, so it's very unusual, except for one we're going to talk about in a minute. Most of the time blood pressures are not affected. Fatigue, diaphoresis, things like that, as we talked about with newborns. Newborns don't sweat. So if they are sweating, that could be an indication of some underlying problem, one of which may be a cardiovascular problem. So, when we're talking about diagnostic studies related to cardiovascular dysfunction, our studies are no different than adults when it comes to this. So, they can look at a EKG first. It's very unusual to have EKG changes in children. There's only one that we really focus on in children that we'll get to in a little bit. But for the most part, your EKG is not necessarily going to reflect a defect. The big one we use is an echocardiogram, or an echo, you'll hear it called for short, where they can actually use an ultrasound picture to look at the anatomy of the heart as well as the blood flow in the heart, and that can tell you if there are openings that aren't supposed to be there, if there's restrictions that aren't supposed to be there, things like that. And of course, the gold standard, just like in adults, is cardiac cath. They can use this not only for diagnostics, where they can go in and get a good visualization inside the heart with a camera of what's going on, but they can also do interventions. For instance, if they have a hole in their heart, which we're going to talk about those holes in just a second of what they are, they have a hole, they can actually patch that hole through cardiac cath. It doesn't always require an open chest kind of surgery, which is nice. So as far as these diagnostic and these interventional type of studies, the implications for nursing, again, is actually no different. They still, with a cardiac cath, have to lay flat and keep their legs straight. You still need to do your frequent neurovascular checks. If they're immediately out of cardiac cath, that's probably going to be as much as every 15 minutes. They're probably going to be getting those Q15-minute vital signs. You're going to be looking for bleeding at the site, applying pressure to the site, monitoring eyes and nose. All those things you learned about adults, you do as your post-procedural cardiac cath care, still applies to children. They will give them IV fluids to promote excretion of that contrast dye, because I know you've learned about in adults, contrast dye can be harmful to the body if left in. So you want to make sure that they have good kidney function, so they're excreting it rapidly. You want to make sure they're limiting activity for at least 24 hours post-cath, because they're not necessarily going to be admitted just because they had a catheterization. This can be often done, especially with if they're just putting a patch on their heart or they're just doing something diagnostic. It could be where they go home that day after monitoring for a few hours. So teaching parents about these implications as well. So when you hear the term congenital heart disease, what does that mean? So congenital heart disease just means that they were born with it. So children can have congenital heart disease where it was an instance they were born with, or they can have acquired heart disease, which we'll talk about in a minute, that can happen, for instance, from a post-strep complication. So congenital heart disease is actually more common than people realize, especially some of your more or your less severe ones, for instance, your ASD, VSD, PDA, which, what do those words mean? We're going to talk about in a minute. It can be associated with other types of defects. For instance, Down syndrome babies have a much higher risk of getting VSD, or ventricular septal defect, than the general population. So sometimes they're associated with other disorders. Sometimes we just don't even know why they happen, and they just happen. Something happened during that fetal development that caused an opening in the heart. So we have three big classifications. So the two I have listed here are acyanotic and cyanotic. And then the third one we'll talk about in a minute is your restrictive defects. So let's talk about the difference in your acyanotic versus cyanotic. So the big difference is some cause cyanosis and some do not. It really is the difference. So when we're talking about an acyanotic defect, these are ones where it's basically because these are your holes. So because there's a hole in the heart, either between the two ventricles or the two atria are the most common, it's causing just recirculation of that blood. So it's not where the blood is skipping over the lungs to get oxygenated, it's just getting recirculated, which seems like a good thing. More processed blood is better, except this is causing extra workload on the heart, and we're going to get into detail on this in a minute. Whereas your cyanotic is where there is some kind of defect that's causing it to skip over the lungs, at least part of the blood, so that part of the blood going out to the circulation has not been oxygenated. So you'll hear them called, so your acyanotic ones are often referred to as your left to right shunt. It's getting to the left side of the heart, but then being recirculated back to the right side, which means it's just going through again. And your cyanotic, you'll hear them called a right to left shunt, because it's on the right side of the heart and it's skipping over to the left without going through the lungs. So that causes that cyanosis to occur. So again, another way we can identify the two types. Congenital means at birth it was already present. And it could be a variety of different ones. It is usually going to be some kind of anatomical defect. Versus your acquired ones are something that happens after birth. The most common one is where you get that mitral valve prolapse, which occurs related to that post-strep infection effect. Another thing that your German measles or your rubella can also cause similar symptoms. So that can give you an acquired heart defect later on in life. So acquired just means it happened later after birth. Congenital means it was present when the child was born. So again, when we're classifying defects, there's three main ones. This focuses on your acyanotic versus your cyanotic. So again, your acyanotic is going to be your ones that increase pulmonary blood flow. This is going to be your left to right shunts. So these are ones where you're not going to have patients turning blue, but because of the increased processing of the blood through the heart, it can result in things like fatigue and symptoms like that. And eventually, without treatment, if it's a significant cardiac defect, could lead to congestive heart failure. So when we're talking about, again, increased pulmonary blood flow, I want you to think of holes in your heart, and holes that occur by themselves in the heart. And you'll see what I mean in a minute when we get to our decreased pulmonary blood flow. There is a disorder where a VSD is part of it, but there are other defects that result in a much more significant defect. So when we have just a hole by itself, we have increased pulmonary blood flow. So the most common three that you see are your VSD, or ventricular septal defect, your ASD, or atrial septal defect, and then your PDA, or your patent ductus arteriosus. Out of the three, the one with the best best outcomes is your atrial septal defect, as far as ones that's between your ASD and your VSD. So with your ASD and your VSD, the only difference between the two is anatomical location. So they are both a hole, and the ASD is between the two atria, the wall that separates the two atria. A VSD is in the wall that separates the two ventricles. Size is going to matter in terms of outcomes. And this varies from patient to patient. There's no format to decide what makes for worse outcomes other than size. Sometimes these holes will close on their own potentially. Sometimes they need a surgical intervention, such as having a patch placed through that cardiac cath to close that hole off. It's going to depend on the patient. The other one, a patent ductus arteriosus, is not really a anatomical defect. More so that valve that was supposed to close when the fetus was born did not. So I went into this a little bit when I talked about fetal circulation. So in fetal circulation, you have valves that alter the flow of blood because a fetus is not getting oxygenated from their lungs like they do once they're born. They are getting oxygenated by mom. So they don't need the blood to be going through the capillaries of their lungs. So they have specifically the PDA, the patent ductus arteriosus, connects the pulmonary artery to the aorta. So it's basically just skipping the what am I trying to say? Sorry. The lungs, so that it's not getting oxygenated through there. Well, ideally, when a fetus is born, that valve, with the changes in the intrathoracic pressure, and when that baby takes the first breath, that valve should snap shut. Sometimes it doesn't. And this is why newborns, oftentimes a murmur is not concerning. A murmur in and of itself is pretty common and not concerning. Sometimes it'll take a couple days for this PDA to close, even naturally. Sometimes it takes a little longer. Most of the time, they're just going to watch it. If they start seeing significant symptoms, they may close it themselves with a surgical operation. But other than that, a lot of times it's just a watch and wait kind of thing. Babies may live with this. It oftentimes closes on their own, though. So a lot of times, especially your smaller acyanotic defects, are not super concerning, depending on more the severity of symptoms, and the size of the hole is what they'll focus on. So I'm going to skip over the cyanotic defects only for a moment, just because tetralogy of flow is a little more detailed. And I'm just going to talk about the restrictive defects for a second, and then we'll go back to that. So restrictive defects are exactly what they sound like. This is where you have some kind of stricture in the vasculature to cause decreased blood flow. So if you think about hypertension in an adult, when they have hypertension in an adult, it works backwards with symptoms. So when you have, for instance, hypertension in the aorta or systemic hypertension, that left side of that heart has to work harder, which results in you having that congestive heart failure and those symptoms of that left-sided CHF, such as backup in the lungs and things like that. Well, with these restrictive disorders, you can also get the same thing because it's causing that heart to work harder. So the two most common ones that you see in pediatrics is, the first one is called coarctation of the aorta. And if you look at the picture on the left-hand side of the slide, this is where you have a stricture in, or a narrowing in the aorta. And the location of it is important for diagnostics, and you're going to want to know this. So if you notice where that stricture is, right to the left of that is the blood vessels. You see them going upwards because those are the major vessels going to your upper extremities, to your head, and all of those. So because of this results in blood pressure changes. So the difference you'll see in blood pressure that is diagnostic for coarctation of the aorta is they will have higher blood pressures in their upper extremities than their lower extremities. And the reason for this is, think of that pressure that left side of that aorta is trying to push against to get through that narrowing. It's backing up into those blood vessels going up into the head and the upper extremities. So those those upper extremities are going to have those higher blood pressures than those lower extremities, which can be a problem because how many times have you been in the newborn nursery and you've seen them do 4-point blood pressures? I can almost guarantee you your answer is never. This used to be part of the newborn assessment, just like rectal temps used to be part of a regular newborn assessment, and you're not seeing those things done anymore. And the problem with that is unless they start to show symptoms, this may go unrecognized, and symptoms meaning signs of congestive heart failure. Such as crackles in the lungs, for instance, because this would be a left-sided problem. So sometimes it's not always caught right away. So those higher blood pressures in the upper extremities are diagnostic for this. The other restrictive defect you may see in children is pulmonary stenosis, where you have a narrowing in that pulmonary artery. So in this case, you may have those right-sided CHF kind of symptoms, such as the edema and the ascites and the backup of fluid in the systemic system. So both of these mean there's a restriction in blood flow, which can cause, similar to hypertension in adults, that backup of blood, as well as the more work that corresponding side of the heart is having to do. So how they can treat these disorders, there are various things they can do. They can put a stent in, just like they'll do when somebody's having a heart attack. They can do balloon dilation, where they take a balloon and it's almost like a Foley balloon, but not a Foley, where they're stretching that valve out to hopefully open it up. They can take that valve out and replace it. There's various different things they can do depending on the severity of the child and the individual presentations and all. So going back to cyanotic versus acyanotic, let's talk about the cyanotic defects. So the big one I want you to know about cyanotic defects is called tetralogy of Fallot. It's almost a little over halfway down the slide if you want to know how to spell it. Tetralogy of Fallot means there are 4 disorders that make this up. So you need to know the names of the 4 disorders that make up this problem. So you have a ventricular septal defect, which is labeled as number 1 on that picture that is on the right side of your PowerPoint. Number 1, you have a VSD. So you have an opening between the left ventricle and the right ventricle, which, like I mentioned, by itself is not always super concerning. However, this is a defect where you have not only that, but you have other defects working with it to result in a poor outcome. So the other things that you also have an overriding aorta. I know I'm skipping down a little bit, but I'm going to tell you how they fit together. So you have a VSD, that opening between the 2 ventricles, and then you have an overriding aorta. And what this overriding means, that instead of that, and it's labeled as number 4 in the picture, instead of it just coming out of the left ventricle, it's coming out right over where that opening is, where that VSD is. So it is pulling blood not just from the left ventricle, but from the right ventricle as well. So because of this, especially when you have increased cardiac output, like for instance, when baby's eating, or when baby's crying, or when baby has a fever, when you see those increased cardiac output situations, that's when you'll only see the cyanosis sometimes, because that increased cardiac output, it can't pull more from the left side, but it can pull more from the right side. So it will start pulling unoxygenated blood faster than oxygenated blood. So that's how those 2 go together. So you've got that opening between the left and the right ventricles, and then you have an aorta that's right over that opening. So it's pulling from both sides of the heart. So your other 2 defects, number 2, is your pulmonary stenosis. So that is that narrowing of that pulmonary artery. So because of that, you get that backup that we talked about. So just like in adults, when you have a narrowing or something that heart is having to push against, on that side of the heart, you're going to have hypertrophy. And that's where number 3 comes in, hypertrophy of the right ventricle. That right ventricle gets the thicker muscle wall because it's having to work so hard against the pulmonary stenosis. So muscles, anytime you work them hard, when you go to the gym and you work out your muscles, they get thicker, they get bigger. Your heart is also a muscle. When it has to work harder, it gets thicker and bigger, which means the actual chamber of the heart heart where the blood fills gets smaller. And as that chamber gets smaller, there's less room for blood to be pumped. So this results in even less blood being pumped over to the left side of the heart to get oxygenated. So as this disorder gets worse, you see worse symptoms. So it may just start out how a friend of mine's baby was diagnosed. Luckily, they were still in the hospital when it happened as a newborn. They were feeding the baby, and all of a sudden, baby started turning blue. They did an echo, and that's when they found this disorder. Um, it can't be fixed in one surgical repair, and you don't need to know the names of the surgeries that are involved, but it actually requires about 2 to 3 surgical repairs, usually done over time during the first year of life, to fix this defect. Children that have surgeries to repair this often have really good outcomes. So without correction, it doesn't always result in very good outcomes, but they can often get surgically repaired to have much better outcomes. So one thing that occurs, like I mentioned, with babies that have this is called paroxysmal hypercyanotic episodes, or oftentimes you'll hear it called TET spells, because it's associated with tetralogy of flow. And often all this is where they turn blue related to often some kind of activity. Sometimes it can be idiopathic. They're just sitting there watching TV and they turn blue. There's various different reasons this can happen. So some of the symptoms you'll see, they may have cyanosis, they may have tachypnea, they may have tachycardia, they may even have loss of consciousness, they may have diaphoresis, all those symptoms that can indicate that there is some kind of reduced oxygenation. So I've seen them last as much as a few minutes. It could last a few hours. It just depends on how significant it is and how quickly it's addressed. And again, this can occur because of many things. If they have a fever and they have increased cardiac output, if they're eating, if they're crying, all these things. But what is important for me that I want you to know is, what do you do about it when it happens? So whenever they have a TET spell or a hypercyanotic episode, the treatment for this is knees to chest. And as you see in the picture with that baby, the parent is pulling their knees up to their chest. And what this does is it increases venous return and hopefully will improve the amount of blood that can get oxygenated. And usually it helps. Another thing that you'll see older children do is squat. It's the same process. It's putting their knees up to their chest. And they have actually seen, I mentioned this in class a little bit, how they've seen in other countries with adaptations. Children that were never taught to do this will squat down when they're feeling like they're hypoxic, as a natural adaptation to improve the outcomes of these TET spells or these hypercyanotic episodes. So knees to chest or squatting, which produces the same effect, is the method to alleviate the hypoxia associated with the hypercyanotic episodes. So the last thing we'll talk about with congenital defects are what are called mixed defects. Oftentimes these defects are incompatible with life for very long. So even though they may be born with it, they often don't live past a couple years of age maybe. So these are the 3 big ones. We're not going to focus on them too much. I want you to focus on the other ones because they are more common, but you should at least be able to recognize these if you saw the descriptions. So transposition of the great vessels is definitely one that is very much incompatible with life for very long. This is literally where the pulmonary artery and the aorta are transposed. So they are in the wrong places. They are used interchangeably instead of where they're supposed to be. So because of this, there is no communication between the pulmonary system and the systemic system. So you can see where that is a problem. Then you have the truncus, or the truncus arteriosus, and this is where you have that VSD, but you also have that single vessel. So it's mixing into both. This is not necessarily incompatible life. We just talked about tetralogy of flow. This is two things that happen with tetralogy of flow. So this can be fixed with a surgical repair, usually in the first month of life. And they'll close that VSD, they'll attach that pulmonary artery, and things like that, so that they can have kind of a normal output. The one I've probably seen the most of these mixed in fact, the only one I've actually taken care of patients in, of the mixed defects, is the hypoplastic left heart syndrome. This one's pretty significant. So the left side of the heart is either underdeveloped or not developed at all. They may have no left ventricle, and because of this, they also have aortic atresia, which means it's missing that opening. So because of this, they have that patent foramen ovale, those valves which keeps them alive, but it can't keep them alive forever. So oftentimes these patients have multi-stage surgeries again to fix it. But every patient I've ever had with this had very poor outcomes, died within the first couple of years of life, and they stayed blue. They would actually be blue in color at baseline, because they maintain a cyanotic effect. And these were patients, I know you've talked about in when you talk about COPD patients, you don't want to give them too much oxygen because it can make them stop breathing. So with this case, usually these patients, you keep low sats, like you maintain their oxygen to keep their sats. The last patient I had was between 75 and 85% is what the goal sats were for this patient, because you didn't want to put too much extra work on the heart and all, because their baseline was cyanotic. But we're not going to focus on the mixed defects too much, but so you recognize those terms. One thing you should already know everything about is congestive heart failure. Congestive heart failure is no different in children than it is in adults. There is something causing increased work on the heart that is causing backup of blood flow, causing those either pulmonary symptoms or systemic symptoms, depending on if it's left-sided heart failure or right-sided heart failure. The difference is, though, in adults, you're talking about acquired conditions like hypertension, for instance, that has caused this, versus in children, usually it's caused by some kind of anatomical defect, like, for instance, that BSD or whatnot, or that tetralogy of flow that's causing that backup as those ventricles get hypertrophied. So the manifestations are the same. Again, it's going to be based on whether it's right-sided or left-sided. If you're talking about left-sided heart failure, that's where you're typically going to get your pulmonary symptoms. If you're talking about right-sided heart failure, you're going to get more of your systemic symptoms. So on page 1238, there's a figure that outlines the clinical manifestations if you're unsure of those at this point. The most common cardiac drug we give in pediatrics is digoxin. So I recommend you know digoxin well, when it comes to cardiac. It gives you detailed information of what you need to know in your ATI book about administration of digoxin, things that you look out for related to digoxin, and it's on 117 of your of the newer book. Since we're switching to the 2019, it is on 117 of the new 2019 book. So some important things with digoxin. One thing is always checking that heart rate and blood pressure before you give it, and that's with children as well as adults. The difference is what level we hold it for. Usually with adults, you hold it if their heart rate is less than 60. Since children have a higher heart rate than adults, you're going to have a higher heart rate you're going to hold it for. So in children, it's generally said to hold it if their heart rate is less than 70 beats per minute. In infants, it's less than 90. You're going to hold that. So they're really focused more on the heart rate because, like I've mentioned before, we're not as focused on blood pressures in children as we are in adults. Another important thing to teach parents is to teach them how to check the heart rate at home. A lot of times we always teach the best way to check a heart rate in a patient in the hospital is to check an apical heart rate and listen for a minute. Still absolutely the best way to do it. But if you're sending a patient home, most of them are not going to have a stethoscope and a means to do that. So teaching them how to do a radial pulse or a brachial pulse if they're under 2, and making sure they understand the importance of that before they administer that medication. Making sure they're monitoring those serum levels, Therapeutic levels are very important, and there's not a huge range for this medication, 0.8 to 2, when you're talking about those blood levels. That doesn't give you a lot of wiggle room before you can either not be therapeutic or start to have symptoms, as well as knowing monitoring for signs and symptoms of toxicity. The big hallmark symptom that's different from others is those halos. So if you got especially a younger child that can't tell you their vision looks funny, if they're rubbing their eyes a lot, that could be a sign that they're seeing something funny. Um, Especially if they're having symptoms like vomiting along with it, or any other symptoms that may indicate that. Bradycardia is another symptom of toxicity. So make sure you know digoxin pretty well, because it's a really common drug, the most common drug that we use in pediatric cardiology. So our management of CHF, or congestive heart failure, just like in adults, the number one drug we give for CHF is your diuretics. It's talked about on page 1239. The big diuretic we use in pediatrics is furosemide. Lasix is the drug of choice, the gold standard for diuretics in pediatrics. We really don't use Bumex or bumetadine in pediatrics. It has more likelihood for side effects and more likelihood for drawing off too much fluid. For that reason, furosemide is the big gold standard in pediatrics. In addition to that, oftentimes they'll be put on some kind of antihypertensive if they have hypertension related to it, which as that CHF builds, that can certainly lead to your problems with blood pressure. The most common drug that we probably use is your ACE inhibitors, especially your enalapril. And this will help reduce some of that afterload. So we won't go into a lot of discussion about arrhythmias in children, because there's not a lot of arrhythmias in children. Generally, when we're talking about children, it's too fast or too slow. You don't have the heart blocks that we go to in children, and you don't have AFib and AFlutter and all those things that you're going to talk about extensively in med-surg too. The only real cardiac arrhythmia problem that you see in pediatrics, specifically that we're going to talk about, is SVT, or supraventricular tachycardia, which is what you see on the strip right here. So what happens with SVT is it's above the ventricles, so supraventricular tachycardia. So what happens with this, they can go into it idiopathically. It's not always a reason. Sometimes stress can bring it on. There are children that are more susceptible to it. It can start in infancy. There was a few of you that were there with me on 2 different clinical days where we got to see and experience an infant who had just gone in for his well check, and found out they couldn't count the heart rate manually because it was going so fast. It was beating at over 200 beats per minute. And when we put him on the monitor, found that he was in SVT. The most important thing regarding SVT that I want you to know is how to treat it. So when we're talking about any kind of treatments, and this goes for adults as well as children, we try to use the least invasive to most invasive. The easiest thing should come first. So you don't want to automatically go into shocking them when there may be other maneuvers that can work easily. So one of the things we did for this baby that actually worked well and nothing else had to be done is we just put ice on his face. Sounds mean, right? But what that does is it shocks them. It makes them take a deep breath, and it has an effect on that vagus nerve, which can oftentimes kind of bump them out of that SVT. In older children, you can have them bear down. Like I've had to hold my arm out in front of them and tell them push down on my arm as hard as they can, and that forces them to bear down, especially in younger children that might not understand what bear down means. Having them blow through a straw forces them to exude that excess force. So these vagal maneuvers, the ice, paring down, the blowing through a straw is a least invasive way that hopefully you can help their body come out of it naturally. If for some reason that doesn't work, the drug of choice is called adenosine, and we're not really going to focus on the drugs in the cardio version that much for the purposes of this course, but you will get it extensively right at the beginning of med-surg too. So it's a good thing for you to know adenosine helps basically reset the heart. So it doesn't slow it down, but it resets it. It is given very quickly, rapidly, as fast as you can through that IV. And it is essentially, it stops the heart and lets it restart, almost like turning off a computer and turning it back on again. Patients that have had it that are old enough to know what's going on, they say it feels like somebody kicking them in the chest. And it can stop for sometimes 10 seconds and can feel like the longest 10 seconds of your life as a nurse and even as a patient. So I've been told. Another option we have is called cardioversion. So the difference in cardioversion and just shocking somebody like with an AED is that an AED is for somebody who does not have a rhythm, and you're putting the paddles on them and you're giving them a shock. With cardioversion, it shocks them just like that, except that you set the machine to shock at a certain point in their cardiac rhythm, because if it lands on the spikes, that QRS you're seeing, then you can actually send them into cardiac arrest. So it's synchronized, meaning it hits at certain parts in the cardiac rhythm so that you are not sending them into cardiac arrest. So that's usually your last option. One easy way to remember it: stable, vagal, unstable, cable. Meaning if they're stable, if they don't have symptoms, and sometimes, especially in the beginning, they won't have symptoms. It takes a little bit for their body to start decompensating. So if they're asymptomatic and you see an SVT, try the vagal maneuvers first. If they are unstable, if they have had loss of consciousness, if their blood pressure is declining, if they have other symptoms, then you're going to go right to that cardioversion. And that's a term we use in ACLS, is stable vagal, unstable cable. So another arrhythmia we see pretty commonly, especially in infants, is your bradycardia. With bradycardia, oftentimes it is related to, unless you have a patient who has a cardiac defect, it is usually related to a respiratory problem. We talked about this a little bit with newborns. When you have a declining heart rate, if you bag them or do something to bring their respirations up adequately, usually the heart rate will follow, unless there is something actually cardiac going on. The large majority of the times it is something respiratory. And all the pediatric codes I've been in, I've never been in one where they actually had to shock the patient, because we may have to do respirations, we may have to do chest compressions, especially if their heart rate in infants, if their heart rate gets below 60, we start chest compressions, even if respirations, if we start respirations. But we may have to do respirations, we may have to do chest compressions if it gets low enough, but never have I seen where they actually have to shock the patient, because shocking is only going to happen in your actual cardiac patients. But patients that just have some kind of respiratory depression or respiratory problem, as they're decompensating, that heart rate will drop as well. So if you fix the respiratory problem, the heart problem will usually follow. So one disease that you will see in the pediatric population that people have often not heard of, because it's pretty uncommon, is called Kawasaki's disease. With Kawasaki's disease, this is a reaction, usually of no known cause. It's a vasculitis that occurs. So because of this will help you remember the symptoms. So symptoms, when you think of symptoms, I want you to think of red. I want you to think of a red motorcycle when you think of Kawasaki's disease. So symptoms associated with Kawasaki's disease include a really high fever, significantly high fever, 105, 106. And this will go on for several days. Oftentimes they'll have what we call strawberry tongue. We'll see the term, you'll often see it called, this is where they'll get the pinkish red tongue with the darker red dots on it. It'll look just like a strawberry. So strawberry red tongue. On their hands and feet, they'll get the really red hands and feet, and they'll peel as well. They'll get bloodshot red eyes. They'll get a rash, especially over the torso. So sometimes, especially in the first few days, it can be hard to differentiate between Kawasaki's disease and potentially strep. Some kids can get a pretty significant strep reaction. Um, but that strawberry tongue is a big difference in the two. So it is self-limiting, but usually these kids get admitted with Kawasaki's disease. They always get admitted and the reason is not because of the disease itself. It is usually self-limiting. Most kids do not have complications from this. They usually have great outcomes, but the problem is of the potential poor outcome. The biggest thing you are concerned with is because it is a vasculitis or an inflammation of the vascular system, you can get aneurysms. While rare, they can occur. And if you develop an aneurysm that ruptures, there's no better place to be than in a hospital. If you are at home and you develop an aneurysm that ruptures, a lot of times there's nothing that can be done by the time you get to the hospital, potentially, depending on how severe it is. So death is pretty rare, but usually when children die, it is because of those ruptured aneurysms. So we talked about before, very rare to give aspirin to children. And this is one of those cases we do give aspirin for. So one treatment of Kawasaki's disease is aspirin. And what this does is it reduces those potential for those cardiac anomalies or the aneurysm. The other treatment that we will give is IV immune globulin or IVIG, and this will help the body fight that infection to hopefully make it where they don't have those complications. Again, complications are rare, but the significance of it is so severe that these kids always get complicated, even if they just suspect Kawasaki's disease, because you don't want to take that risk of sending them home and then they do develop that aneurysm. So the number one concern with Kawasaki's is aneurysm, and we give aspirin to hopefully prevent that complication. So we've talked a little bit about rheumatic fever, not really in detail. We talked about a little bit with rheumatoid arthritis and those autoimmune effects that can occur because of strep. So what happens with rheumatic fever is where you have an untreated group A strep. So this is the strep that gives you strep throat, not the group B strep like women have in their vaginas. So when they have this untreated strep infection, it becomes systemic infection. It is where this infection, the autoimmune reaction to the strep, starts attacking connective tissues. It starts attacking things like your joints, your heart, your kidneys, your nervous system, where you can get the chorea, the involuntary movements. It can attack multiple parts of your body. Sometimes children will have only one effect, like they might just have kidney failure from it. Sometimes they can have multiple effects from it. So it just varies from person to person. It's that destruction of connective tissue is what is causing these problems as an overall thing. So this is why we worry about strep infections, not because of the strep infection itself. Strep is a pretty self-limiting disease to be a bacterial infection. If you don't treat it, for the most part, it will go away on its own. But you worry about those post-strep effects. Which are most common between the ages of 2 years and 16 years of age, but it can occur outside of those parameters as well. So that's why it's always important to treat strep. No matter the severity of symptoms, you don't want them to have those post-strep effects. So when we're talking about rheumatic fever, treatment of this again is aspirin. One of the things that we will treat this with is aspirin, and it helps decrease some of those inflammatory effects related to the attacking of that connective tissue. They don't stay on aspirin, they only get aspirin during that initial exacerbation. So, initial exacerbation with rheumatic fever, they will get aspirin, and bed rest is another common one. If they have joint involvement, like we talked about with rheumatoid arthritis, we will often apply heat to those joints to help with that as well. So how do we treat it? So again, bed rest aspirin, antimicrobial therapy, because that's what we need to do to treat the strep, and making sure they take the full dose. And most of the times, this is going to be a longer process compared to when you just have a strep infection. They usually just take amoxicillin or something like that for 10 days. With this, they may take it for 6 weeks just to help prevent those post-strep complications from developing even further. And hopefully that will go into play and help prevent worse progression for that rheumatic fever, because you can get rheumatic fever and with good treatment maybe not have those long-term side effects, but again, you might. So strict bed rest, that limits the workload on the heart. Aspirin limits some of that anti-inflammatory, or limits some of that inflammatory reactions. And then steroids also to decrease that autoimmune response. Antibiotics to kill off the strep. Steroids, they'll use initially, as well as if they develop those post-strep complications on a long-term basis, they may use steroids as a maintenance drug as well. So one of the complications of rheumatic fever, specifically to the heart, is where you can get endocarditis related to the actual defect they get is mitral valve prolapse. But what happens when you get that mitral valve prolapse is you get this vegetation that builds up on that valve. And what can happen is anytime they have something that could potentially cause infection, it builds up on that valve and can cause a systemic infection. So typically, when you think of patients that are prone to bacterial endocarditis, especially related to strep, is if they know they have a disorder such as rheumatic heart disease, where they are prone to these, they will get prophylactic antibiotics for dental procedures, surgical procedures, anything that could even increase their risk of infection. So on page 1251, it talks about the manifestations. Oftentimes, the manifestations are a little more vague, a little more insidious. They may have a low grade fever. They may just have kind of flu like symptoms, malaise, weight loss, petechia, things like that. So it's not always going to be heart specific that they have this infection, but being that it's an infection in the heart can cause some pretty significant effects overall to the patient. So when patients have rheumatic heart disease, the number one concern you have is preventing endocarditis from occurring, because it can be difficult to treat.